Podcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil.
I must share this good news with all our listeners that we have recently completed 15,000 downloads for ICU Primary Prepcast. So congratulations.
And thanks for listening, everyone.
Okay, great, Maddi. So we have completed most of our pharmacology episodes and we are kind of heading into our physiology episodes. So what are we discussing today?
Today we're going to start with endocrine physiology.
Okay, so that's one of my favorite topics. So let's start with something which is very basic. Tell us, what is hormone?
A hormone is a chemical messenger produced by an organ which is released into the bloodstream and which then regulates the action of other tissues. Classes of hormones are polypeptides, steroids, or amines. Polypeptide hormones are synthesized as prohormones, stored in vesicles, transported dissolved in blood, and then act via binding to receptors on cell membranes through the activation of second messengers. Examples of these include insulin and glucagon. Steroid hormones are synthesized from cholesterol. They have minimal storage, are transported via carrier proteins, and act via binding to intracellular receptors, therefore directly changing gene expression. Examples of steroid hormones include cortisol and estrogen. Finally, amine hormones are synthesized from tyrosine. They're stored prior to release and act either via membrane receptors in the case of catecholamines or directly on nuclear receptors in the case of thyroid hormones.
Okay, now we are going to discuss one particular gland today, and we'll probably head into the other glands over the period of time. So let's start with pancreas, because again, it's one very favorite topic for examiners. It's often asked in exams. So can you please describe the exocrine functions of pancreas?
Sure. So the pancreas has two main functions, an exocrine function which aids in digestion and an endocrine function which helps control blood sugar levels, which we'll talk about later. So in the terms of the exocrine function, approximately 95% of the pancreas is exocrine tissue, the functional unit of which is an acinus and its draining ductule. These ducts eventually culminate to form the main pancreatic duct, which then joins the common bile duct at the head of the pancreas to form the ampulla of Vater. The acini synthesize digestive enzymes which are stored in zymogen granules and are released by exocytosis into the ducts. The epithelial cells lining the small pancreatic ducts secrete bicarbonate and water. Exocrine pancreatic secretions, or pancreatic juice, is produced at a rate of 1.5 litres per day and is highly alkaline with a pH of around 8. The digestive enzymes secreted by the pancreas help to digest proteins, carbohydrates, and fats. So firstly, the enzymes that digest proteins. The most important ones are trypsin, chymotrypsin, and carboxypolypeptidase. Of these, trypsin is produced in the largest quantity. The proteolytic digestive enzymes are initially synthesized in their inactive form, trypsinogen, chymotrypsinogen, and procarboxypolypeptidase, known as zymogens. Trypsinogen is activated into trypsin by enterokinase, which is secreted by intestinal mucosa in response to the presence of chyme. Trypsin then activates chymotrypsinogen, procarboxypolypeptidase, and phospholipase A2, and can also activate trypsinogen itself. In terms of carbohydrates, the pancreas produces pancreatic amylase, which helps to digest carbohydrates. And for fat, the pancreas produces pancreatic lipase, cholesterol esterase, and phospholipase. Pancreatic lipase is secreted in its final form, but its activity is significantly enhanced in the presence of colipase within the duodenum, which is activated by trypsin. The acini themselves also secrete trypsin inhibitors, which prevent activation of trypsin and thus prevents activation of the other proteolytic enzymes within the pancreas. This helps to avoid autodigestion of the pancreas. Bicarbonate and water are secreted by pancreatic ducts. The first step in the formation of bicarbonate is the diffusion of carbon dioxide from the blood into the ductal cells. Carbon dioxide and water then forms carbonic acid by the presence of carbonic anhydrase. The carbonic acid then dissociates into bicarbonate and hydrogen. The hydrogen ions in the cell are exchanged for sodium ions within the blood by secondary active transport. The bicarbonate ions are then actively transported with these sodium ions into the ductal lumen. This movement of sodium and bicarbonate into the duct results in an osmotic gradient, causing water to also move into the pancreatic duct. This pancreatic juice helps to neutralize the acidic contents coming from the stomach, which allows for optimal enzymatic action. The pancreas is innervated by the vagus nerve, which is activated in response to seeing, smelling, or tasting food, and also activated by stomach distension. Vagal activation causes the release of acetylcholine, which stimulates the secretion of pancreatic enzymes via phospholipase C. Pancreatic secretion is also activated by hormones secreted by the enteric endocrine system. These are cholecystokinin and secretin. All of these stimuli act synergistically and have multiplicative effects. Cholecystokinin is secreted by the eye cells in the duodenal and the jejunal mucosa in response to food entering the small intestine, especially in the presence of long fatty acids and protein. It has a greater effect than vagal stimulation on the secretion of pancreatic enzymes and also acts via phospholipase C. Secretin is secreted by S cells in the duodenal and jejunal mucosa in response to acidic chyme with a pH of less than 5. Secretin has a large effect on bicarbonate and water secretion by the ductal tissue by an increase in intracellular cyclic AMP. There are 3 main phases of pancreatic secretion: the cephalic, the gastric, and the intestinal phase. The cephalic phase is initiated by the senses involved in food consumption and mainly involves vagal stimulation, which causes secretion of pancreatic enzymes with relatively less bicarbonate and water secretion. The gastric phase is initiated by the presence of food within the stomach and mainly involves vagal stimulation. And finally, the intestinal phase is initiated by the food entering the small intestine, which causes the secretion of cholecystokinin and secretin, which then stimulates pancreatic digestive enzymes, bicarbonate, and water. The majority of the pancreatic secretory response occurs during this intestinal phase.
And I think the exocrine function of pancreas is equally important as its endocrine function. So it's very worth spending time in learning about or remembering about these exocrine functions. Now let's move into the endocrine part of the pancreas. Can you please describe the various endocrine functions of pancreas?
So the endocrine component of the pancreas consists of small islands of cells known as islets of Langerhans, which secrete hormones into the bloodstream. There are 1 to 2 million islet cells, and they consist of 4 main types: A or alpha, which is 25% of cells and secrete glucagon; B or beta, which is about 75% of the cells in the islets and secrete insulin and amylin; D or delta, which is 3 to 5% of cells which secrete somatostatin; F or the PP cell, which is less than 1% of cells and secrete pancreatic polypeptide. Although the islets comprise just 1 to 2% of the total pancreatic mass, they are highly vascularized, receiving up to 15% of pancreatic blood flow. The main endocrine function of the pancreas is to maintain glucose homeostasis, which we'll describe a bit later in this podcast.
Okay, so as you mentioned, there are 3 main hormones that are secreted by pancreas as a part of its endocrine function. Let's start with the most commonly asked hormone in the exam, that is insulin. Can you please describe the physiology of insulin?
So we have discussed the physiology of insulin in our pharmacology podcast on diabetic agents, but I'll briefly outline it again here. So insulin is a small protein which is synthesized in the beta cells of the pancreas from proinsulin and comprised of two amino acid chains, A and B, which is connected by a disulfide linkage. An increase in plasma glucose causes glucose influx into pancreatic beta cells via GLUT2 transporter, which is then phosphorylated to glucose 6-phosphate by glucokinase. This is then metabolized to pyruvate, which is metabolized to CO2 and water via the citric acid cycle with consequent formation of ATP. The ATP then inhibits potassium-sensitive ATP channels, resulting in depolarization and the opening of voltage-gated calcium channels. The calcium influx causes the secretion of insulin via exocytosis. So insulin has an effect on carbohydrate, protein, and fat metabolism. In terms of carbohydrates, insulin results in increased uptake of glucose by cell membranes through hexose transporters, especially GLUT4, thereby decreasing blood glucose levels. Importantly, the liver and the brain do not require insulin for efficient glucose uptake. Insulin also causes increased storage of glycogen in the liver by increasing the activity of glucokinase and glycogen synthase, and by inhibiting liver phosphorylase, glucose 6-phosphatase, and gluconeogenesis. In terms of fat, insulin promotes fat synthesis and storage via the activation of lipoprotein lipase, the promotion of glucose transport into adipose tissue, the promotion of fatty acid synthesis, and the inhibition of hormone-sensitive lipase. Insulin also inhibits kerogenesis and lipolysis. For protein, insulin promotes protein synthesis and storage by increasing cell permeability to amino acids, increasing the translation of messenger RNA, the inhibition of protein catabolism, decreasing gluconeogenesis, and synergistic action with growth hormone to promote growth. Insulin also increases the potassium uptake into cells.
Thanks. And as you mentioned, if listeners want to get an in-depth knowledge of insulin, please go and listen to our endocrine pharmacology podcast that we recorded this year. Now, let's move on to the other two hormones, namely glucagon and somatostatin. Can you please describe the pharmacology of each?
So glucagon is a polypeptide secreted by alpha cells from proglucagon in response to decreased blood glucose levels in order to increase these levels. It has a half-life of between 5 to 10 minutes and it is metabolized mainly by the liver. Glucagon also affects carbohydrate, fat, and protein metabolism. In terms of carbohydrates, glucagon causes glycogenolysis in the liver and increases gluconeogenesis. In terms of glycogenolysis, it acts via G protein-coupled receptors, resulting in a cascade response via activation of adenyl cyclase and increase in intracellular cyclic AMP, activation of protein kinase and phosphorylase, which then leads to the breakdown of glycogen and causes increased blood glucose levels. It also activates phospholipase C, which causes glycogenolysis by an increase in calcium. In terms of protein metabolism, gluconeogenesis increases the rate of amino acid uptake by the liver, which then converts it to glucose. It is ketogenic due to the oxidation of fatty acids, and it causes protein catabolism by increasing amino acid oxidation and inhibition of protein synthesis. Glucagon's effect on fat is lipolysis via the activation of hormone-sensitive lipase, which breaks down fat into free fatty acids and diacylglycerol. The glycerol is used for gluconeogenesis, and the free fatty acids are converted into ketone bodies. Glucagon also inhibits the storage of triglycerides in the liver. Other effects of glucagon include a positive inotropic action due to an increase in cyclic AMP, and the stimulation of growth hormone, insulin, and pancreatic somatostatin. So in terms of the regulation, glucagon is regulated by metabolic, hormonal, and neural factors. In terms of metabolic factors, a decreased plasma glucose level stimulates glucagon secretion, as does an increased amino acid level. An increased fatty acid or ketone level inhibits glucagon release. In terms of hormonal factors, cholecystokinin, gastrin, glucocorticoids, beta-adrenergic agonists all stimulate glucagon, while somatostatin, insulin, secretin, and alpha-adrenergic agonists inhibit glucagon. In terms of neural factors, beta-adrenergic stimulation increases glucagon secretion, whereas alpha-adrenergic stimulation decreases glucagon. Vagal stimulation also increases glucagon secretion. Other factors include exercise, which stimulates glucagon secretion. Now, coming to somatostatin, this is a hormone which is secreted by delta cells in the islets of Langerhans within the pancreas. It is a polypeptide containing 14 amino acids. It is also secreted by the hypothalamus as growth hormone inhibitory hormone. Somatostatin has a short half-life of just 3 minutes, and it's thought to prolong the time over which nutrients can be absorbed by an action on G protein-coupled receptors, which causes an inhibition of a vast array of hormones. Somatostatin has effects on the pituitary gland by decreasing growth hormone secretion and decreasing the release of thyroid-stimulating hormone. It also affects the CNS by inhibition of the release of dopamine, corticotrophin-releasing hormone, and noradrenaline. Its effect on the pancreas includes the decreased secretion of insulin, glucagon, cholecystokinin, and secretin. And its effect on the gastrointestinal tract include decreased gastrin, motilin, and vasoactive peptide, decreasing the motility of the stomach, duodenum, and the gallbladder, and decreasing nutrient absorption from the GIT and gastric acid secretion. It is stimulated by an increase in glucose, amino acids, fatty acids, GIT hormones, or increased growth hormone.
Okay, now remember folks that similar to insulin, glucagon and somatostatin both can be used as drugs, and so they do have a role in pharmacology as well. So that can be asked as a question either as a physiology or in the pharmacology. Now let's move on to the application of all these different hormones. And can you please explain how the blood glucose is controlled in our body?
Sure. So normal blood glucose in humans is between 4 to 6 millimoles a litre, and this is precisely regulated despite variable caloric intake by a negative feedback system consisting of sensors, an integrator, and effectors. So in terms of the sensors, the main sensor is in the islet of Langerhans cells within the pancreas. And as we discussed earlier, glucose enters the pancreatic beta cells via GLUT2 transporters and causes exocytosis of insulin via the production of ATP, cell depolarization, and calcium release. Other sensors include glucokinase within pancreatic and liver cells, which phosphorylates glucose to glucose 6-phosphate, but is also thought to be a sensor in its own right. And finally, the satiety center within the ventromedial hypothalamus and the hunger center in the lateral hypothalamus also act as glucose sensors. The integrator for this system is the endocrine pancreas, and the effectors are numerous and include the pancreas, liver, autonomic nervous system, and the CNS. The main effector is the pancreas, which produces insulin, glucagon, glutamate, and somatostatin. So insulin, we've discussed earlier, but in summary, activation of insulin via hypoglycemia causes increased glucose uptake, glycogenesis, glycolysis, fatty acid, and protein synthesis. The activation of glucagon in situations of hypoglycemia cause glycogenolysis, gluconeogenesis, lipolysis, ketogenesis, and decreased protein synthesis. Its effects are often thought to be the opposite of insulin. Glutamate is also produced as a byproduct of the citric acid cycle, which is stimulated by glucose entry into the pancreatic beta cell. Glutamate causes maturation of insulin granules within the pancreas and is thought to be responsible for a further prolonged release of insulin in situations of hypoglycemia. And somatostatin, which we've discussed earlier, is stimulated by increased blood glucose and reduces gut motility, which is thought to reduce the nutrient absorption and both insulin and glucagon release. The liver is another important effector within the regulation of blood glucose, and it acts as a glucostat and buffer for blood sugar, mainly through the actions of insulin and glucagon. It adjusts the rate of glycogenolysis or glycogenesis depending on the blood sugar. This minimizes the variations in blood sugar levels and helps to maintain homeostasis. The autonomic nervous system and catecholamines are also effectors within blood glucose control. Beta-adrenergic stimulation stimulates both insulin and glucagon secretion by the pancreas, but increases gluconeogenesis and glycogenolysis in the liver. Alpha-adrenergic stimulation inhibits insulin and glucagon secretion. And finally, in terms of the CNS, hypoglycemia affects the hypothalamus and causes activation of the hunger center, which stimulates appetite. It also stimulates the sympathetic nervous system, growth hormone, and cortisol release, resulting in symptoms of hypoglycemia, decreased peripheral utilization of glucose, and increased gluconeogenesis. In contrast, activation of the satiety center in the hypothalamus by increased glucose inhibits this hunger center.
Great. Now, another question from the applied physiology is the effects of insulin deficiency. So can you please summarize them for us?
So the effects of insulin deficiency can be thought of resulting from extracellular glucose excess, but intracellular glucose deficiency. The glucose excess is due to the decreased peripheral utilization of glucose and increased gluconeogenesis by the liver. This causes a hyperosmolality of the blood, which results in glycosuria and an osmotic diuresis, which can then result in dehydration and polydipsia, hypotension, tachycardia, and in severe cases can result in coma. The increased blood glucose also increases renal blood flow and GFR. The loss of sodium and potassium in the urine due to the glycosuria causes electrolyte imbalances. And the decreased transport of potassium intracellularly causes hyperkalemia, but often with whole body potassium deficits. Hemoglobin A is glycosylated to form HbA1c, which is then used as an indicator of glycemic control for the preceding 4 to 6 weeks. And chronic hypoglycemia leads to increased production of reactive oxygen species. The intracellular glucose deficiency causes inadequate hormonal sensing in the part of the hypothalamus that regulates satiety, which can result in hyperphagia. The glucose deficiency also causes abnormal effects on fat, carbohydrate, and protein metabolism. So in terms of fat, there's increased catabolism of fat for energy. Hormone-sensitive lipase in fat cells are strongly activated, which causes hydrolysis of stored triglycerides. A large quantity of fatty acids and glycerol is released into the blood, and free fatty acids become the main energy source for the body, except for the brain. Glucagon also contributes to the mobilization of free fatty acids. The excess fatty acids in the plasma promotes liver conversion of fatty acids into phospholipids and cholesterol. This results in increased plasma lipoproteins and promotes the development of atherosclerosis. Furthermore, the excessive acetoacetic acid formed in the liver in the absence of insulin, but presence of excess free fatty acids, causes the carnitine transport mechanism for transporting excess fatty acids into the mitochondria to be activated. This results in beta oxygenation, which releases acetyl-CoA. The acetyl-CoA is condensed to form acetoacetic acid, which is released into the blood and transported to the peripheral tissues, where it is converted into acetyl-CoA and used for energy. However, in the absence of insulin, there's decreased utilization of acetyl-CoA by the peripheral tissues. Therefore, the acetoacetic acid concentration continues to rise, and some is converted into beta-hydroxybutyric acid and acetone, which are ketone bodies. This can result in metabolic acidosis and a compensatory respiratory alkalosis. In the absence of insulin, there's also a decreased synthesis of fatty acids and triglycerides. In terms of protein, lack of insulin causes protein depletion and increased plasma amino acids. Protein storage ceases when insulin is not available, and there's increased protein catabolism, decreased protein synthesis, and increased amino acids within the plasma. These are used as substrates of gluconeogenesis and is also stimulated by increased glucagon. The use of protein as substrates for gluconeogenesis causes muscle wasting, poor growth, and immunodeficiency. And there's also an increased amount of urea that's excreted within the urine. Finally, the lack of insulin effect on carbohydrates causes increased adrenal glucocorticoids, which causes increased gluconeogenesis. And there's minimal uptake of glucose by skeletal, cardiac, smooth muscle, and liver cells, which causes decreased glycogen storage.
Okay, so let's consider clinical scenario. A patient who was kept nil by mouth, who is diabetic, and accidentally he was given his morning insulin dose. What will be the physiological response that one should anticipate as a result of hypoglycemia in this patient?
So hypoglycemia is a low blood sugar, but there's no confirmed definition of the level that this occurs at. It's clinically confirmed by the presence of Whipple's triad, which is low serum glucose, symptoms of hypoglycemia, and resolution of these symptoms with glucose. It results from an absolute or relative imbalance between the availability and the utilization of glucose. So the glucose availability is determined by the oral intake and by the endogenous rate of glucose production. Endogenous causes of low BSL include liver failure, renal failure, drugs such as ethanol or certain oral hypoglycemic agents, endocrine deficiencies, and enzymatic defects in glycometabolic pathways, such as glucose 6-phosphatase deficiency. Imbalances in glucose utilization can also cause hypoglycemia. So excess utilization by tissues is usually due to inappropriate levels of insulin secretagogues, or rarely by antibodies that act on insulin receptors. And increased glucose metabolism by tissues can also cause hypoglycemia, as in the case of exercise, weight loss, sepsis, and pregnancy. Hypoglycemia itself, like in this patient's case, results in key physiological defenses. So the first response is usually at a BSL of about 4.5 or less, and is a decrease in pancreatic beta cell secretion of insulin. However, as the hypoglycemia worsens, there is an increase in the pancreatic alpha cell glucagon secretion, and this often occurs at a BSL of around 3.6 to 3.9. This results in increased gluconeogenesis and glycogenolysis. There is also an increase in catecholamine-mediated and acetylcholine-mediated neurotransmission by the autonomic nervous system. This response occurs at a higher BSL level in children as compared to adults. The increase in the autonomic nervous system activation can also activate the adrenal medulla, which secretes adrenaline and noradrenaline, and activation of the sympathetic nervous system, which releases adrenaline and noradrenaline that act on the liver via beta-2 adrenergic receptors to increase glycogenolysis and gluconeogenesis. These hormones also increase lipolysis. The activation of the sympathetic nervous system and the autonomic nervous system is thought to also result in some of the hypoglycemic symptoms which prompt carbohydrate ingestion. So adrenergic symptoms from adrenaline or noradrenaline include palpitations, tremor, and anxiety, and cholinergic symptoms caused by acetylcholine release from sympathetic postganglionic neurons include sweating, hunger, and paresthesia. As the BSL continues to decrease, there is also a release of counter-regulatory hormones, including growth hormone and cortisol, which decreases the utilization of glucose in the peripheral tissue. When the BSL decreases further, there are neuroglycopenic symptoms from the CNS because of glucose deprivation. Initially, this begins as cognitive dysfunction and lethargy, but can progress to coma and finally permanent brain damage and death if the hypoglycemia is not corrected.
Thanks, Maddi. Now, folks, we are making few changes in the ICU primary prepcast structure, but I can assure you that we are not making one change to this podcast, that is Maddi's jokes. So I guess, Maddi, you got a joke for me?
Yes, I do. It's the highlight of the podcast for me.
Well, for everyone.
Okay. How did the diabetic tree control his blood sugar levels?
Maddi, can you please ask me some simple questions at least one time? Diabetic tree controlling blood sugar by fasting?
No. With Plantus.
Oh, Maddi, that was again good joke. I should give it to you. So, folks, just before we close down, there are a few things. So, these podcast show notes will be available now on the website critcareedu.com.au along with the podcast episodes. What that means is you can actually access all the notes and the diagrams related to this podcast beneath the podcast on that website. So don't forget to log on to critcareedu.com.au. And also, please don't forget to write a review on iTunes because your reviews and feedback are very valuable to us. So thanks for listening. And Maddi, what are we discussing next time?
So next time will be endocrinology part 2, physiology. So we'll start with discussion of thyroid.
Thanks, folks. Thanks for listening. See you next time.
Thanks.